Hello and welcome. I am Humphrey Hawksley. This is CareVision's Professional Talk and podcast, where we discuss issues on health and social care that are critical to all our lives. The talk part is a prompt about communicating with each other, how professionals talk between themselves to civilians like myself, hopefully in a language that we all understand. The professional bit refers to colleagues and peers in similar lines of work, but often different specialisms. And today, I'm very privileged to have as my guest a clinical psychologist whose expertise is working closely among those with complex special needs and disabilities. Too often, the disability itself supersedes everything. How can overstretched care staff understand ongoing mental health when somebody has limited capacity to communicate and the goal of the moment is to hoist them to the bathroom safely? But if this psychological element is ignored, what are the costs to that person's overall health and quality of life? To answer this and many other questions, welcome Dr. Steven Carnaby to CareVision's Professional Talk.
Thank you, Humphrey. It's very good to be here.
It's really good to be here. Now, just to get this right, Steven, Dr. Carnaby, what do we call
Steve
you?
is fine.
Steve, okay,
Steve is
let's
fine.
everybody call him Steve. Just say that listen to what Steve has to say. Any questions, any comments, any suggestions, any contradictions, put them in the chat and we feed them into the conversation. And hopefully we'll get stir things up a little bit. Now, before we get into some of these issues, really serious issues that we've been discussing between ourselves, ground us how you chose this career. The clinical psychology bit, and then the specialism of the field of special needs.
Great first question. I think the psychology part, probably, and with hindsight, so this wasn't a plan to be completely transparent, probably for me was grounded in lived experience. So I grew up in a family where there was a lot of poor mental health, my father mostly. So as a very young child, I now realise I was perhaps doing some programs with him around agoraphobia and all kinds of issues around anxiety that he was experiencing at the time. So I think probably I grew up being curious around people's mental health, wondering why people did what they did. Was very fortunate to have a mother who modelled for me really how to support people well. Was very inspiring. So I think I grew up in that environment. Learning disability, though, I think was, again, more accidental. I did voluntary work with autistic children when I was studying, really enjoyed it. And it was a chance meeting, really. Some friends at the time had that contact, so I got involved there. And I started frontline support work. And I've always said that's where I think I got my grounding. That's where I really started to understand the nuts and bolts of people's lives and just how important it is to be alongside people, really, and try and get a real sense of their lived experience.
So for your frontline support work, that was as a clinical psychologist?
No, as a care worker, a support worker.
As a care worker, okay. As a care
Yeah,
with
so
people with disabilities?
Yes, yeah.
Okay.
Yeah, and loved it and was hooked, really.
Yeah.
And brief CV, went on from there to managed services for a while, worked in day services as well for a bit, and then got a teaching job at University of Kent. Found that I was becoming a bit more distant from the coalface. I wanted to go back into to real world again, and decided on the psychology route as probably the most helpful way to do that because it opens so many opportunities. But I went into training knowing that learning disability and autism was my passion. That's what I wanted to do.
Right. And
I finished training.
And I mean, why was it so compelling?
Well, I think I was quite unusual in thinking that, to be honest. So in the cohort of 32 trainees when I was doing my training, only 4 of us were interested, which was a surprise to me. But I've always said to people on placement with me, when I have them on placement as trainees, if you can work in this area, you can work in any area
Right.
really, because it's so so layered, it's so complex, there's so many different ways, different ideas, different things to think about. And what I really enjoy is that the whole variety of what you do. So you're working with individuals, you're working with families, you're working with staff teams, other professionals, whole systems, whole networks, all of the above. So it's very varied. And that doesn't suit everyone.
Mhm.
But also I like the long-term nature of the work. So for some psychologists, they're very interested in short-term interventions, a few sessions of CBT. That's not at all wanting to disparage that approach. But
CBT is what?
Cognitive behavior therapy. So where you're using talking therapy to address anxiety, depression, whatever the issue for the person might be, but it's a conversation. It's more of a talking medium,
Yeah.
which is important for lots of people.
But this is a much deeper level, isn't it? I was doing a bit of due diligence on you, Steve, in my things, and you were writing academic papers back in 1997, a couple of them saying, evaluating an established individual planning service for people with learning disabilities. I then Googled what there was on it, and there appears to be one course at Cardiff University that sort of touches on what you wrote there. Am I right in that? Is there still a dearth of this sort of understanding?
Well, I think some language has changed over the years from when I was writing that piece of work in particular. So person-centered planning now is more contemporary. So person-centered planning is a vehicle, as the name I guess implies, where the person hopefully is at the center of conversations to try to think about their aspirations, their goals, what makes a good day, what would enrich their life, what's important to them, what's important for them. And what I was trying to do in that piece of work that you looked at, Humphrey, was at that time trying to understand the extent to which the person themselves was involved in conversation.
That's interesting. Yeah.
Because what I found from personal experience was that where people had words and were able to use words to express their interests, their needs, the process was fairly conventional. The person would be consulted and their views would be sought and so on. Where people didn't use words, there was a lot of talking over the person's head, and I felt that more needed to be done around how do we really understand what this person wants and likes and what's important to them. And just because someone doesn't have words to express themselves doesn't mean to say they don't have a viewpoint.
Yes.
So
has that changed since 1997?
Well,
has your pioneering work made progress?
I think there's certainly a lot of progress. So there's an amazing colleague, I'll name her, Sam Sly, who I've got a lot of time for, who uses the life path method. And for people interested, I can give you her contact information. But she does some incredible person-centered planning with individuals and their families, their networks, and takes time and listens to people, which is it's an obvious thing, isn't it, really? But she listens to people and uses methods that work for them. And that's so important. So joining that person and trying to get a sense of how that person experiences the world, and with their network would create a path, a sense of the future and how to get there. So that's certainly very different to what was around when I was writing.
Ed, I wanted to get in detail with you of how you carry out assessments with people who don't have full capacity in a moment. But before we get there, we've talked on this program a lot about trauma, particularly amongst young people and children, so they don't identifying it, how to deal with it, so they don't fall through the gaps. Can you, and I'm sure you're familiar with that thing, but put that for us in the context of someone with a disability, even if they have full mental capacity, but they have a physical disability from birth or learning difficulties or something like that? Just give us that context.
Okay, so it's vast, to be honest. There's a lot to say about this. So I'll try and give a few headlines. But I think for me, and this is a fairly new, I think, in terms of practice and support to what happens on the ground, this is an evolving field still, I would say. But there's increasing understanding that the very nature of having a disability in a society that doesn't really, if we're being completely honest, I would suggest socially include everybody. If there's a sense of other or difference, it's quite hard to find your place as a citizen in the community. So I think just by virtue of having a disability itself is traumatizing and stigmatizing before one starts to then think about experiences that the person might have because of how you're viewed. And then sadly, we know that having a learning disability makes you far more vulnerable to abuse from others of all kinds. And certainly, there are very few people that I've worked with over the years that haven't experienced abuse of some kind or another. Sometimes more extreme, sometimes quite subtle, sometimes abuse in a form that maybe those around them wouldn't term it as abuse. But for me, if you're being controlled, if you're being stopped from doing things you want to do, if you're not able to have liberty, then that would have an impact on you. I would argue. So there's all those areas to be thinking about and how they affect the person's presentation and how they affect that person's self-esteem, their confidence, their identity, and so on. And what's becoming increasingly apparent is the more challenging the behaviour the person is presenting, the more concern we might have, the more risks there might be around what the person's doing, the more likely there is to be some form of trauma underneath what's going on for them. And certainly the more kind of bizarre or hard to understand the things the person is doing, again, the more likely there is to be some form of trauma underneath what's going on for them.
And what you're Joe's, there's a chilling and I don't know way that you describe that, but thank you for that. But you need to get beyond that to find out what that trauma is, and that's a challenge in itself, isn't it?
Yeah. So it's about listening to
Right.
people that know the person best, and there's this word expertise is used a lot. I personally, the only expert here really is the person themselves, I would suggest. The family and people with experience of being with that person are experts as well, of course, and have expertise that they can share if people are willing to sit and listen and talk with them and hear what they have to say. So it's very much would be very much a co-produced approach where people are sharing their observations, sharing what's happened. Sadly, there are some people where family isn't around, and in adult services, we might meet them as an adult. And what I always find so upsetting is when that person's history isn't available.
Okay.
And we don't know what's happened. We can guess because of what they're doing now, perhaps, or we can, because of where they've lived or environments maybe that they've spent time in, we can speculate what they've been through. But sometimes, archive records don't always give you the full picture. So, yes.
Are you able to? I don't want you to, give details of everybody in particular. Go into a little bit more detail, sort of paint an example of a person that you might see what their behavior or their situation might be, and then how you would tackle it.
So, there's a kind of shorthand that sometimes is used around what an assessment might involve. So if you're trying to understand why someone is doing what they're doing, what is this person saying to me through what they're doing? If the person has words, of course, they can hopefully tell you. And but where that isn't possible, so the first thing I would be thinking about is to identify what are we concerned about? What is the person doing that concerns us? Should we be concerned? Is it just something that's unusual or unconventional? Or is it something that's a concern because that person is causing harm to themselves or to other people? So that's the first thing, to describe what the person's doing, to understand or to get some information about how often it happens, what impact does it have, how long does it last, and so on. In what environments does it happen, and so forth.
Mm-hmm.
And then ask people. So use standardized tools to gather information about events around the behaviour of interest, but also other aspects of the person's life. So their physical health, their mental health, their history, how they spend their day, what's important to them, how they communicate, which is really important. So communication is the cornerstone, really, of all of this, I would argue.
Mm-hmm.
So we would work very closely with speech and language therapy colleagues, or I would like to anyway. That's always keen to try and do that. How do we understand, as I say, what the person is telling us? We'd go and spend time with the person in their environment, different environments, if that's appropriate, to see how they respond to the world around them, how people respond to them, what kind of relationships they have, and then put all of it all together, which takes a bit of time, to come up with a hypothesis. What's our best guess as to what's going on with this person? And it's multifaceted, and you're kind of looking at a multitude of areas, a whole person approach, a whole environment approach.
Mm-hmm. But if we go back to, say, somebody who's got a learning disability, physical disability, self-harming, say, and then you have a number of issues there that I sort of see is, one, you have to communicate, and they're not verbal or they can't communicate with you. You're then dealing with the care staff, if they're in residential, who could be defensive about what they're doing. So you might not get a picture. Am I right in that, or am I?
So that can be the case, but I'd suggest that might be because of the approach that you're taking. So again, having been a support worker myself, I know how hard the job is. It's a really intensive, enjoyable, but very intensive job. It's not for everybody. And some people fall into support work for great reasons, and they're talented, and it's the perfect match, and they do amazing work with people. Other people, unfortunately, might fall into that work for other reasons, by accident. It's not really a good match for them. I always say to support workers, I invite them to consider, what is it about working with the most vulnerable people in our society that actually lights your face up? What is it about that is important? Why do you do this? What are your reasons? And some of those reasons are healthy, and some of them aren't so healthy. Because at the end of the day, staff always have the power. But don't always feel that way. They sometimes feel that, he knows what he's doing. He's doing it on purpose. He's doing it to wind me up. All these attributions can be used. But at the end of the day, staff can walk away. So it's trying to understand where staff are coming from. And if they are defensive, again, that means something. But I think there is a way to join a team, have conversations with them, understand what's important to them, how they're feeling about what's going on, what are their traumas, because we all have trauma in our lives. We all experience difficult things.
So you're assessing a number. You're assessing everybody in the. We have a comment in from Lynn here, who's actually on the lines that we're talking about here. Listening and involving those with learning difficulties in their own plans is obvious, but so often it happens that it's tokenistic, and they are directed into what the professional thinks is best for them, regardless of what the person and the family think. The professional always, in capital letters, knows best, or so they think. They can communicate. People just have to be prepared to listen and give them process time. Is this what you're saying, Steve? Is Lynn right?
Agree more with Lynn. 100% spot on there. And I think just to say to that, to speak to that for a moment, even where people use words to express their wishes, because of the power imbalance in service land, there can be a risk of acquiescence and willing to please, worrying about saying the wrong thing, worrying about being in trouble, worrying about their services and their help and support being cut in some way. So I think Lynn's right, to be confident that we're getting an authentic view from someone takes a lot of time, patience, and probably a few attempts to build a rapport before getting the actual opinion from the person. And trying to get that sense in the round is important. Seeing them in different environments, talking to different people, and doing that over time so that you're more confident that you're really trying to get some insight into what's happening for them.
So, you talked at the beginning about being seen as different, being othered, which is just something that we might not immediately understand, but this is the lived experience of disability is traumatizing in itself, and trying to break that with you also, or somebody going in and analyze and assessing also that the care staff to make sure that they understand what's going. This is a job that it seems to be very necessary, but also has to be resourced.
Yes. And at the moment, there is a shortage of psychologists generally, I think, but particularly in learning disability. It's changed over recent years, so there more people are coming into the field. There's there's more interest, and it's an exciting time because the research is building. We've got a great understanding of what mental health problems look like in someone that doesn't use words to express their internal experience. So it's a field that's ever evolving. But you're absolutely right. It's very resource intensive to do it properly and thoroughly. And waiting lists build. There's pressures for people to get through waiting lists. I was sometimes, when I worked in my statutory sector role, was sometimes criticised for being involved for too long, hand holding care providers being alongside assistants for too long, because there's other people waiting, and I understand that. It's trying to be fair to everybody.
But of the millions that are in the special needs category now, and however many are in supported living or residential, a fraction of those would get the sort of support that you've just outlined.
Well, it's hard for me to comment, but yes, I would probably think you're right, Humphrey.
Would you imagine? And I'm saying, because we have a comment or a story from Dorothy Wood. Would love to hear more, Dorothy. She says she's been told that she's too complex to help, been told that she has to get used to being bullied. Is that something that sounds familiar to you?
This word "too complex," I mean, that's shocking, really, because if someone's needs aren't too complex, says who, really? And we all have needs, don't we? But I think it's surely that if someone's needs are complex, the more it's more important to try to understand what would be helpful.
Yes.
No one's too complex. That seems absurd, really.
It seems. Dorothy, if you could give us another line of your context, your circumstances. We don't think it's a son too complex, because yes, too many disabilities. The Stephen Craig. We'll go back. We'll come back to that, because I want to talk about that more. Stephen Craig. The system in Scotland has been legislated to ensure that services are needs led, not directed by diagnosis. However, we are still failing to support neurodiverse children and their families. Excuse me. What advice would you give to professionals and families trying to take on the system? What is the difference? Just explain the difference between needs and diagnosis.
So I would hazard a guess that's making a comment around formal assessment. So sometimes diagnoses are used as a gatekeeping strategy. so one part of my work that I didn't enjoy in NHS was as a psychologist was where we were asked to carry out IQ assessments to determine whether someone met part of the criteria for a learning disability service.
Mm.
And there's a whole session by itself, Humphrey, to talk about IQ. But and it's not the only thing that you would look at, but it's a component. And some services, I think, probably still use those assessments as a way of saying yes or no to whether you have support or not. And there are lots of people who are very vulnerable indeed, who need support but don't tick the diagnostic.
Oh, I got you. Yes, yeah.
In the way that services often set them up to be, which I've got a huge problem with. But I think it's about, I would suggest, in terms of how to fight the system, it's about rallying together. I mean, I think families, when joining forces together, have incredible power, and it's important that that's not, that's something that is galvanized really. And because what I often say to staff is that we will come and go, staff come and go, a family won't. A family's always there, will always be there.
Yes.
We have no right to start dictating what should and shouldn't happen. A family,
This phrase "fight the system," which I think anybody in the industry has heard for, as soon as they stepped into it. What does it mean exactly? Because those in the system, like you, I mean, you were in the system at one stage. You were there because of your father, and that sort of thing. So they must have some kind of understanding of. So what exactly are they fighting?
That's a very big question. I guess they're fighting people's attitudes and views, aren't they? At the end of the day, there still seems to be a postcode lottery in terms of funding, for example, and finding a friendly ear who's willing to listen and understand one's experience can be a way in. It shouldn't be like that. It shouldn't be about. It should be about a system that's fair to everybody. But it does seem to vary hugely. Different parts of the country, families, different experience things very, very differently from each other, from what I can see.
It's about swinging around the bureaucrats to, and also they have to find the money, don't they? So there's that one.
Yeah, in a time where I remember, so in 2005, or prior to 2005, I was working in a part of London that was comparatively well resourced at that point, and I remember my very wise manager, who sits on my shoulder still, said, "It's all going to change, Steve. Things are going to really get quite difficult." And she was absolutely right. And I think now we're at a point, sadly, where it's not just cut to the bone. The bones are now dust. There's such a shortage of funding. And I think I would say to a family, I do encourage families, keep shouting. And it's interesting, sometimes you'll hear professionals say this family is, inverted commas, difficult, or other words that I'm sure you can mention what other words they might use.
You get the difficult tick, don't you? And then
yes. And I say, well, that's great, because that's a family that hasn't given up and is fighting. We all would. If it's your son or daughter or brother or sister. I had a sister, sadly no longer with us, who needed a lot of physical support. She had multiple sclerosis, and I'm sure was a nightmare brother, because I would say it how it is. If things weren't in place for her, I would say so. But
I think I just want to go to back to Dorothy. Rosie says, Dorothy, don't accept such things being said. That is wrong and not good enough. Definitely challenge them, maybe get a Care Act advocate. Dorothy then comes into some detail. Autistic, blind, epilepsy, PDA, OCD, CPTSD+++. Can you translate that for us, Steve?
from what I heard there, that there's a complex PTSD, so complex post-traumatic stress disorder.
Right.
PDA, it's not a term that I'm fond of. I think it is a thing, but I think the words, as you'll see, pathological demand avoidance.
Okay.
Some people with that description of their profile have coined a more positive term, which is persistent drive for autonomy, which I prefer, which is, it's in a sense finding any demand difficult, even if those demands are internal. So PDA is often associated with people who are autistic. Didn't quite hear the other descriptors that Jonathan mentioned. Sorry.
OCD. That was the other.
Obsessive compulsive disorder.
Yes. So, Dorothy, Steve's website is in there. Would it be all right if she gets in touch with you and maybe you could have an extra conversation?
Absolutely. Of course.
Yes,
Of course.
because
Because I think what's tricky is, I'm generalizing outrageously here, but sometimes what can happen is, for children, there is quite rightly a lot of intensive assessment to try and actually make out the profile of different diagnoses. What's important then is how those diagnoses interplay, how they combine, what do they mean, what do they look like, I suppose, day to day for that individual. And so the diagnoses themselves, that's part of the approach. But for me, it would be about a formulation, which is just really a map of understanding. How do we help these different things, how do these different components, if you like, or these parts of someone's presentation, how are they interdependent? How do they combine and lead to helping us to understand this person's experience? And what does then that drive us to do to be helpful? What does good support look like?
Yeah.
So my concern is sometimes things stop at the actual assessment stage.
Yeah.
And assessment that's great. Detailed assessment is helpful. But then what?
Yeah.
The assessment needs to lead to formulation to then intervention.
I'm gonna come back to that in a moment after I got through the comments that are coming in, because this is the bit where I want you to tell us how the rubber hits the road, as it were, so that so the ones you've done. But Dorothy, please get in touch with Steve. He will pick up the phone, have a word with you, because that's what this show is all about. And hopefully set you on a better path than you are at the moment, because I think from the comments coming in, you have the support of all of us here, that, it is not acceptable to say that he has to get used to being bullied. Stephen Craig, I'm setting up a community support group within Care Visions in which families will be able to support each other to get it right for children, regardless of their diagnostic pathway. Anyone interested can email me at stephencraig@carevisions.uk. I'm going to separate that off and put it again in the chat, and we'll make that available. Laura Llewellyn says, the standard tests for autisms require fine motor skills, which a physically disabled person is unable to complete. Interesting.
Yes, that is the case. But again, these assessments are not their opinions, and they're not blood tests or x-rays. So
yes,
often we're trying to understand things that we can't see. And by that I mean, as you would in an x-ray or a blood test with a broken bone or something. It's an opinion, and opinions can be formed, of course, in numbers of ways. And yes, the gold standard assessment tools would often need the person to have a certain degree of motor skill. That's absolutely the case. However, they're just tools. And even with those tools, they still need the assessor to use them carefully, to spend time with the person, to really understand what happens for them, look at their history, talk to people that know them best. So I would argue there are ways around that. It shouldn't be a barrier. to a
Well,
person having good
what sort of
assessment.
fine motor skills are required? And Laura, if you can give us some more details, because I think this is a very interesting issue, is that something's cut off because somebody is physically disabled to do something, and therefore that disability counts against them in their learning disabilities.
So, for example, then some tests would need you to use different kind of blocks to copy patterns from a book. So you need to move the box around. Of course, if you have a visual impairment, you won't be able to see the book or the blocks. So additional disabilities, they need creativity. They need, and there are other tools out there that would supplement these so-called gold standard assessment tools. There are always ways around it. Being told that you're too complex isn't good enough.
Is it because the autism people don't speak to the physical disability people, don't speak to behavioural ability, and they all have their own tests?
So no, well, in part, I think it's more to do with the fact that the actual tools themselves were based on research. So we're talking about evidence-based practice, and what this means is we need, and there are things out there that are appearing all the time, but we need more research to explore other avenues, other ways of assessing people, other ways of agreeing what's going on for the person, to make sure that we aren't going to fall foul of what's called diagnostic overshadowing, which just means we are being overly inclusive.
Right.
Diagnostic undershadowing, where we're kind of missing things. So it's an art form, to be honest. I mean, it's not an exact science, I'd argue, and it needs experience. And things look different in different people. We're all individuals, and I would always say, when if you're a parent and you're wanting your child to be assessed, or a relative or someone that you care about, ask the person's CV and talk to them about other people they've actually assessed. Get a feel for who they've worked with in the past. Are they fresh out of training, or have they been supervised for a number of years? Have they, because to be honest, every time I assess someone, meet someone new, you're learning something new from everyone that you meet. You're starting from scratch in many ways. Yes, there's things that that you've acquired over the years, but every new person, every new situation, there's something brand new to be gleaned from that.
So as advocate or family, you need to assess the credibility or qualifications of the person that's doing the assessment.
I think so.
And ask them,
I think so.
frankly, how Rosie says, thank you for coming back to us, Rosie. It can depend on what part of the country you're in, is the best support about challenging systems. So that's, again, how the system's constructed in whatever parts of the country. Lynn, thank you, Lynn. Part of the issue is that parents, carers, families are exhausted. And having to fight to what is need is frustrating. Funding for what are basic needs, not luxuries, that give quality of life, cause burnout. The fight is knocked out of them. You meet a lot of people like that, Steve?
Yes, far too many, sadly. And families that are traumatized by their experiences of services and what services have done to them or haven't done for them, perhaps.
Yeah.
Just a quick shout out to the Challenging Behaviour Foundation, the CBF.
Right.
I think it's challengingbehaviour.org.uk is the website.
I'm just going to type that in as Challenging Behaviour
Foundation, or CBF for short. And
Foundation.
they are for families, run by families.
Yeah.
Do some fantastic work. Viv Cooper was Viv Cooper in OBE, I should say, who is a mother herself, a young man with severe learning disabilities and challenging behaviour, and she set up her son's support because she wasn't getting what he needed from her local authority, and now has set up this very influential national charity. and they are the kind of government's go-to body really for getting family views.
Mm.
They have a helpline. They have free resources on their website. They run workshops.
Yeah.
Also, and what the reason for flagging them is that they have caseworkers who will attend meetings with you. So if you're having difficult conversations, if you're going to meetings where you aren't being listened to, you've got, there's brick walls that are stopping you from getting what you need, they will come along and support you. I've got the privilege of actually supervising two of their helpline workers, one of whom is the team leader, and they do some really important work.
Happiness. Okay.
So they're always there.
And that could be somebody for Dorothy. I've just
Yes.
seen this knocked out, concussed, and now blind. This is her son being bullied.
Yes.
So that would be one for you, Dorothy. And I've written it into the chat in my way, but I'm sure if we Googled it, that would come up.
Yes.
Back to Laura Llewellyn. This was the autism diagnosis. The psychologist stroke NHS had assessed my son. Her tool was the test that Steve is referring to. Therefore, the assessment was conducted as a, quotes, educated guess. The assessment was for ASC to pass the parcel to ICB to fund my son's 12-hour night care. ASC, ICB, can you translate any of that for us?
Autism spectrum condition. So autism now is referred to as a condition, not a disorder.
Right.
Which personally I think is a great move, because being autistic is just how you are. It's so but again, I suppose that speaks to the point of the assessment being an opinion. I'm sorry, that's Laura's just said adult social care.
Adult social care. Okay, that's from the local council to the health.
To the health.
NHS.
Yes,
Yeah.
no, that's a really good point. So that speaks a little bit to. Thank you, Laura. That speaks a little bit to what I was saying before about the gatekeeping role. So I'm working with someone at the moment where there's batting backwards and forwards between the ICB, between health funding and local authority funding, and it's so stressful for families because it isn't about the person. It becomes about systems and funding streams, and the person gets lost, and that's what frustrates me. So there's a lot of work to be done, I think, around how funding works, the role of joint funding, rather than it being one or the other. And some people might just miss the criteria for health funding, but doesn't mean to say that their health needs aren't important, aren't significant. So it's a bit of a minefield, and again, it varies from from place to place.
As Rosie, I think, said, I mean, just if in a utopian world where everybody with special needs that was in supported living, residential, or whatever, went through an assessment by you and your colleagues, and the care staff were trained and motivated enough to know how to handle their psychological needs,
pay better.
How much healthier would the special needs community be, and possibly how much less cost would they be to the National Health Service?
I think beyond words, really, to be honest.
Yeah, it is utopian.
Well, unfortunately, it probably is, pragmatically, but it's what people are entitled to. It's what they need. It's not a wish or a desire, it's a need. And what again, a drum that I bang continually is trying to help people understand that all behaviour takes place between the person and the environment. It's not in people. People aren't born doing the things that they do. They unfold as a consequence of the world that they're in, and the types of response that they are receiving from those around them. And so it's quite difficult sometimes for support staff and families to be fair, sometimes to accept that unfortunately sometimes we are part, not of the problem, but we are an influence. We are part of the assessment in the sense that how we respond needs to be understood. And that's really important, because the environment doesn't just mean the physical space, it's about everything that happens in that environment.
And so Dorothy mentions forever fighting, and then what could help their extreme anxiety? Rosie, any suggestion that person-centered support is the norm might send local authorities running, that they would really challenge their clinical medical model systems? Yes, it's a good question. Are you qualified to answer it, Steve?
Well, it's a social construct, isn't it? Again, there's a whole other session, but these are arbitrary cut-offs, aren't they? We've decided as a society that this means you're this and this means you're that, and it's labeling, it's stigmatizing, it's compartmentalizing people.
Yeah.
It's the very antithesis of social inclusion, really, isn't it?
Yeah, and Lynn makes a comment, and after the comment, we're going to do the rubber hitting the road. Lynn says, if they get support needed early, this is my question there, it will stop things getting worse and end up needing more expensive intervention, more cost-effective in the long run. That seems to be the view. Rosie, Steve knows me, so won't be surprised by my thoughts. You didn't meant to have a conflict of interest. We've had that, Steve.
Yes, apologies. Yes. But I think I couldn't agree more with what Rose was saying. I mean, it's challenging.
And Dorothy, who is a theme through the show, but thank you, Dorothy. People are the problem. They are bad with people with disability, which is the point you made right at the beginning of this, wasn't it? That however much we try to do it, they are seen as different and they are stigmatized. I just want to go into an imaginary situation, or a real one if it is if you're asked to assess somebody in a residential or supported living or something like that with the situations we've been, just talk us through, you have done before, but talk us through a bullet point of how you would do it, and then how you would not just stop at the assessment, but make it work over the years.
Oh, we got.
We have got less than 10. We got 10 minutes at the most, and I will interrupt.
That's great. So I think I'd start by understanding why I've been called in the first place. So who's most concerned, and is there something to be concerned about? And that might sound like a really odd place to start, but I think he's trying to get a feel for who's been affected by whatever the concern is that's being raised. And then I suppose once that's been identified and we know what the issue of concern is, it's then trying to get a feel for that situation from different standpoints. And that would be a combination of lots of reading of background material, if it's available, talking to the experts, and by the experts I mean the person, if they can talk to me, the experts being the family, the team that work with that person every day, that know them best, people who live experience of that individual, and I guess comparing and contrasting all those different viewpoints, because everyone will speak from their own truth, won't they? But there might be some conflicts and differences and points of view that maybe are contradictory or sometimes are in agreement. So that's important to understand, because that might be that if there is a conflict of agreement or something like that, that might be part of the answer, inverted commas, to try to, that might be where some of the intervention might be placed, for instance. I'd then spend time with the person in as many different environments, and as long as they could cope with that. Some people find it difficult to have someone new in their world, but from my experience, if you take the time, most people will get used to you. You build the rapport. You join them in things that person likes, that's important for that individual. Rarely do people come and see me. I tend to go and hang out with them wherever that where they feel most comfortable. It could be out for coffee, it could be going bowling, it could be in their living environment, wherever that might be, but just to get a feel for what their day looks like and how they spend their time and how people respond to them, what kind of relationships that they have.
I mean, if say you have a special needs home or as I said, a community like that, is there a way for the NHS to do that as a group if they've all got, there must be common ground there a little bit, although everybody is individual? Or would the NHS have to do what you've just described, each one individually?
So I've certainly done both. I would certainly, what I wouldn't do is go in and work with a group as though they're a group, because people are obviously they're individuals, and there's I think quite a risk of treating people as a group. So there might be some common themes, absolutely, but there might be some issues about compatibility, of course, where people are sharing space together. But I would always look at individuals, and then there might be some areas where we could combine
with
and,
yeah. And is it, I mean, it's not done at the moment, is it? The NHS isn't doing it. So if parents, we have people here that are saying they've got problems, should they club together? Should the health, the care provider do it, or how should it work?
I think what seems to be changing, and I'm in, just full disclosure, I'm in independent practice now. I do a lot of work for court as well. So sadly, sometimes by the time things reach me, things have become either crisis point or there's something really, very seriously wrong. Ideally, well begun is half done. So someone mentioned early intervention, but when people are moving into their accommodation, there would be ideally some work done around compatibility, but also making sure those staff are trained, the environment's right for everybody, so people are lively and rich, they're doing things they enjoy, they're doing things that are important to them. But I think you're right. What seems to be happening now, from speaking with my colleagues who are employed by ICBs or kind of local learning disability teams, they're having to kind of firefight, really. Their waiting list is so long, they're having to work with people that are in crisis or on the way to crisis. And so that proactive, preventative work doesn't always happen. A good care provider should be doing that themselves, though, I'd argue. So, and that's about social workers or care managers making sure there's a commissioned package is set out in a way that is going to meet that person's needs, and that if things unravel or things begin to break down, that's when you might bring in the psychologist. So some care providers now have their own psychologists, some have behavioural support practitioners or other fancy names that they might have, but then some might have in-house support. But it is really about trying to get things right from the get-go.
And to have it written into the care plan that's funded then?
Absolutely, because once it's in the care plan, it should be provided.
Right. Okay. And is there a catchphrase that the parent should ask to be written into the care plan that would include what you just outlined is needed?
Not such a catchphrase, but I think just to say that all assessments should be co-produced. So if assessments are taking place without you as a parent, I would push back on that and question why that's happened.
Yeah. And should clinical psychology be used in there, or would that be?
If they're available, I'd say sadly they're not always part of local kind of structures, but it needs someone that's going to be thinking about trauma, thinking about attachment, thinking about emotional development, thinking about mental health, because it's still relatively recently that we've begun to recognise, this sounds absurd saying it out loud, but just because you have a severe learning disability, a profound learning disability, you can still have poor mental health. You can still be anxious or depressed or experience trauma. And that's quite a late, we just say, oh, yes, of course. No. So sadly, that's quite a new field of research still, I'd argue. We're still working out what poor mental health looks like in someone that doesn't use words to express themselves.
I mean, that's a really important thing. You have your disability or your learning difficulty, and then you have your mental health, don't you?
Well, we're all people, aren't we? We're all people first.
Yes,
that's
exactly.
the point.
Yeah.
We happen to have other aspects to ourselves, but we are people that have feelings and emotions and experiences, and that's got to be at the heart of everything.
Yeah, and there's all the young people that have got no disabilities that are being signed on for anxiety and mental health problems at the moment. Which is, Laura says, Laura Llewellyn, this is, I personally believe that the Warnock report became the catalyst for education for SEND to be inclusive to all. Thus, specialist schools were closed, which has set fire to a society where there are few specialisms in education, in care, and a completely useless specialism of residential care and or support living environments. Steve, Warnock report, what was that?
My expertise, unfortunately, so I won't speak to that if that's okay. But I think the principle that you're saying, Laura, I would agree with, and I think it's interesting as young people are moving into transition into adult services, trying to make sure that there's a really good plan for how that happens, because so many children get lots of support or get some support as children, and then there's this almost like off a cliff where, because the adult services have maybe got different values or different funding approaches or just haven't done the assessments early enough, there's far from a seamless experience from one to the other. And that's something that I really worry about. That was something that was talked about back in the 90s, and we still haven't got that right.
And just to sort of wrap up your assessment and taking it on, so that it's not just an assessment that lies in a drawer somewhere, how would you write, or give us an example of sort of 5 bullet points that a weary care staff coming onto a night shift can read and absorb so that they know how to deal with somebody?
It's a really great point. I think it's the kind of holy grail, really, when it comes to bringing a care plan to life. The late and great Jim Mansell, who was a professor at Tizard Centre at Kent University, talked a lot about the implementation gap, so the gap between what we know needs to happen and what's actually done. And there's always a reason why things aren't put into practice, and lots of clinicians can get very frustrated and sometimes quite cross. So why don't they do it? And I've told them what they need to do, they're not doing it. And my response is always, there's a reason why people aren't doing what they've been asked to do. All behaviour means something, and staff are no different. So why can't we apply the same principles to staff that we apply with people that they are supporting? And for me, if staff aren't implementing a plan, it probably means they don't understand it, they're not actually motivated to implement it, they don't agree with it, they perhaps haven't been invited to help to write it. So I've always co-produce everything. It's co-produce assessments, co-produce care plans, write it together. The whole network, I mean, it takes longer, but the whole network needs to feel that they're invested and they have ownership of that plan. Because if they don't, it's imposed upon people. And whenever, I might give a staff team some charts to fill in to actually record when things happen, in the context around a behaviour of concern. And when I go back to see how they're getting on, and a team says, "Oh, we filled your forms in for you, Steve," so they aren't my forms. They're yours. Well, actually, there's a person that you're supporting. They're their forms, but they're not mine. Don't do it to please me. It's not about me. And if those can be red flags to indicate maybe that I haven't quite got the co-production right, because that's really the heart of the thing. Again, I would say.
Yeah, we just have a quick. So Steve makes a huge point. I agree. Mental health disorders are often not appreciated in the context of learning disability and neurodiversity, leads to late diagnosis, poor treatment and support. We are almost out of time. Do not go away, Steve, because I want you to give us a final thought that we can think about and chat about over the water cooler. But time's wing chariot attacks, and our next Care Visions professional talk is at 7 p.m. on Thursday, October the 30th, with the fabulous Ivalia Febra, Children and Families Social Work, specifically child protection, a specialist in social pedagogy, and she's worked in the wealthiest and the poorest of London boroughs. Social pedagogy, we didn't get into that and we haven't got time to do it now, Steve. But before we go, we have talked about so much. And I think this great idea that it's not great, it's a dreadful idea that we don't understand that disabled people have got the same mental health disorders. Give us a final thought that we can go away with.
This is a very basic thing, maybe, but keep the person at the centre, but authentically so. I think person-centred plans are bits of paper. It's about practices that really matter. And actions speak louder than words, don't they? We've got to, keep the person in mind all the time.
Yeah. And don't talk over them.
Oh, absolutely.
Yeah.
And share expertise. And also always remember that as parents, as family, your expertise is core to how things will be assessed and how things need to happen for that person.
Good goodness. Thank you, Steve, for being such insightful,
My pleasure.
Patient, compelling even. But really, thank you so much for this. It's
very welcome. I really enjoyed it. Thank you.
We have applause going up. I'm just going to see, because we're not on a news break or anything. We have got, goodness, too much stuff in here. Linda Layton, a fascinating talk. I hope it's recorded. So interested. Dorothy Wood, thank you, people. Dorothy, thank you, I should say. Laura Llewellyn, thank you so much. Too many, I'm afraid, because we have to go. But thank you all for being here. Thank you for your questions and your comments. Come back October the 30th. See you then, everyone. But for now, stay safe. And from all of us at Care Visions Professional Talk, goodbye.